Okay, I'm going to start. For all you people who came on time, thank you. And I am very excited to introduce Dr. Les Aria. This is a webinar that I would have signed up for if I were a moderator. You know, Les, the title is sort of an overview of modern pain neuroscience and the application of pain reprocessing therapy. Any questions you have, look at the Q&A or chat, and you can ask questions of Dr. Aria through that. This is being recorded, so let everybody know. And if you want to review it again, it'll be in our YouTube channel for CHIP. And then, of course, everything we do for CHIP is free. Donations are welcome. If you want to make a $25 donation so we can keep this going, consider making a donation. Just go to our website, mychip.org. You know, I met Dr. Aria recently, and I was wowed by his knowledge and just communicability. He's been a pain psychologist for 20 years. He's also co-founder and chief clinical officer of Menda Health, and that's on his bio. And this is a digital therapeutic platform for pain recovery. It's adults and children. And his specialty is treating chronic pain, physiologic disorders, and medically unexplained conditions. And these are the bane of a lot of medical subspecialists. Even when they get, gastroenterologists get IBS, they kind of don't know what to do after giving the usual meds and explaining it. So they usually say, see a therapist. Anyway, he has a unique style, and I can't say enough about him. The other thing is, having known about polyvagal neuroscience, he's going to talk about sort of how polyvagal theory underlies a lot of modern pain science. So why don't we start? Thank you for coming, Les. So what's the difference between pain science and modern pain neuroscience?
Yeah, that's a great place for us to start. Hello, everyone, and those who might be watching this as a re-recording. It's a pleasure to be here. The purpose and intention of, if I answer that question, is to make sure that you actually have a shift, perhaps, in how you think about pain and how you might be experiencing it. So my goal is not to convince you. My goal is to have you come down the truth of the line and just make your own decision on it. So I'm hoping you'll enjoy this webinar. So the answer to the question between the difference between old science and modern pain neuroscience can be delineated very simply. Old science says, and when I say old science, I really want to emphasize this. And when I say old science, it's actually taken from, most people may not know this, from René Descartes. Now, most people may go, isn't that a philosopher from the 16th century? Yes. René Descartes, when he started this in the 16th century, basically went about and he taught in medical schools, and he basically separated the mind from the body. Now, I'm using those terms very specifically. I didn't say brain, I said mind and the body, because back then Orthodox Christians could not cut into the body for fear of damaging the soul. That was this belief. And so when René Descartes came in and they wanted to advance medicine couldn't advance until he came and said, yeah, let's do things separately. So old science basically comes with that premise is, if something is damaged or broken, it's because it needs to be fixed in the body. And medical schools, residency programs continue to teach this. Now, at some level, there's a lot of truth to that, because the difference between acute pain and chronic pain are two different things. And it's even processed differently in the brain. Happy to go into it, but for just clarity and summary, old science basically says that the reason you hurt is because there's something damaged that needs to be fixed within you. Modern pain science says, not, maybe. Here's what modern science says. Modern pain neuroscience says the reason you hurt or feel what you feel with your pain experience is because it comes from the brain. Now, mind you, I did not say mind. I said brain. And I want to share something with you real briefly. Last year, I presented at an international conference. It's huge. It's called the Pain Week conference. And we had lots of physicians there and allied health professionals. And it went awry. It went south real fast because I asked this question. I said, good doctors. I said, let's just say you have someone with back pain. Can you point to the body? And I did this. If I have back pain, point to your body part where pain comes from. And about 80 to 90% pointed to the back. And at that point, I knew how to separate who knew what. And about 5 to 10% pointed to the brain. At that point, everyone roared in laughter. And I was a little bit embarrassed because it wasn't a joke. And then they laughed even more, which got worse. This is on my presentation. And I'm trying to educate them the difference between modern and old science. And here's what happened. I said, okay, my doctors, the 80% of you that said, point it to the back. I said, can you please take your brain off your shoulder and place it on the table and let me speak to the back? And they roared in laughter again. And I thought, geez, Louise, this is not going my way. And I started to get frustrated and then realized that they think it's a joke. They thought I was being funny. And that's when I realized really quickly, even after all these years of practicing, modern pain neuroscience has not caught up to medical practice. Not all of them, and I want to be clear on this. I'm not pointing fingers. It's just that we know what we know when we do what we do that we know. And so modern pain science says everything comes from the brain, because if you don't have a brain, watch this. You don't have thoughts, you don't have emotions, and you don't have the pain experience, the sensations in your body. Put your brain back on your shoulder. You have thoughts, emotions, and physical sensations, and that's the separation. One is something is damaged and needs to be fixed. I don't know why. This doesn't make sense. If you have back pain, why do you have, the opposite of where the protrusion is or the impingement is? Why is it shift from one side to the other? Old science cannot explain this. Modern pain science says it's called brain smudging. You ever remember do this in elementary school? You're drawing, you take your saliva and you rub the pencil, it smudges. Well, the brain does the same thing. That's why it's not psychological. And I want to make sure you hear this, is when pain is experienced, sometimes it shifts body part because of what we refer to as brain smudging. And that's not psychological. And this is why there's a psychological component to modern pain neuroscience. That's the suffering, that's the fighting, that's the complaining, that's the fear. Oh my gosh, how do I get rid of it? That's the psychology to it. But this is coming from the brain, and that's the best way I can explain it, is that the separation is neurocircuitry versus identifiable structural issue.
Right. And there are a certain number of people that start out with acute pain. We see kids that have a sports injury and everything heals up, but they still continue with pain. Or somebody has an acute gastroenteritis, the inflammation goes away, but now they continue with abdominal pain, diarrhea, constipation. The idea of acute pain or surgery pain that goes from acute to kind of a little longer than usual to chronic pain. Can you talk about that?
Sure, absolutely. And in fact, I'm going to draw on Dr. Upkarian, AP Upkarian, Karian, Northwestern University. Great lab. One of the first people in the world to show you he can predict who develops chronic pain from acute to subacute to chronic with an 80 to 85% accuracy. That's pretty impressive, by the way, just looking at brain scans. And so what they found out is there are a couple of factors here. Everything, and this is going to be hard to say because I know you might be experiencing pain. I know someone you love that experiences pain, so this might be difficult to say, but I'm hoping that you'll have an open ear. When you experience chronic pain, acute pain, when you have pain less than 4 weeks, everything in the body heals. Everything has a timeline from a tissue tear to a bicep tear. It doesn't quite matter, or even any aspect of your spine. The body heals. It really does. They've studied this. Now, when the body does not heal and goes into the subacute, they actually noticed something in Abkarian's lab. Specifically, they found out two things. What promotes acute to subacute to chronic are two factors you'll be very surprised. You ready? Here goes. During the subacute phase, your brain has to determine whether it needs to protect you or not, because pain is a protector. Think of your brain as a dog and the bark as the symptoms. The purpose of the dog, I have a chocolate lab, and you might hear him bark every now and then. That's when he senses danger and tenses danger. And so what they found out in Abkarian's lab is when someone goes from acute to subacute, less than 4 weeks, less than 8 weeks, subacute, and then if it starts to go between 8 weeks to 12 weeks, starts to branch out the 3rd month, the 4th month, they found out two factors. People during the subacute phase of their pain, when they have fear of the pain and avoidance of movement or doing something that promotes the pain, fear and avoidance can be identified in the brain. I'm going to point to my brain. I shaved for everyone today. I'm just kidding. My head is always shaking. In the nucleus accumbens, whenever we do something, we are teaching the brain. When you fear pain, you teach the brain more pain. When you bring curiosity, a sense of compassion, a sense of courage with fear, we tend to desensitize the pain circuitry in the brain. So in summary, what we did discover is this is what shifts people. This is really, really very neuroscience-ish, that what fires together, wires together. If you have fear and avoidance of pain, you will train the brain. If you learn to bring curiosity and compassion, you desensitize the brain. And it's the same brain chemical. I want to be clear, the bunch of brain chemicals when we shift into acute, subacute to chronic pain. Same brain chemicals when we shift into being curious, compassionate, and desensitizing of the pain. Dopamine. Whenever we learn something, we get a dopamine hit. What I mean by that is this is whenever we learn things from an emotional perspective. If you fear math, you're like, oh, you get the heebie-jeebies in your stomach, you get tension, you get worried. But if you're really good in math, we tend to feel relaxed. In the same manner, when you have fear and avoidance of your pain, sensation, or experience, you get the dopamine hit. What we practice, the brain gets better at. Now, if we bring a sense of curiosity, which I'm going to show you how to kind of do today as part of the demonstration, and the specific intervention is called somatic tracking. And it's been tested in a study done, published in the Journal of American Medical Association, short for JAMA, J-A-M-A. And if you wish, you can go to Google and type in Pain Reprocessing Therapy and JAMA. The first link comes up, and it shows you the world-renowned study that shows that mind-body interventions can change the brain system from pain into recovery. I did not use the word management. I did not use the word cope. I used the word recovery. And so with that said, fear and avoidance seems to be the factors that promote the chronicity of pain. Now, there are other factors, but I'm just being reductionistic for today's conversation.
So I understand that, but I've heard it within the context of polyvagal theory underlying this pain reprocessing therapy. Could you talk about that?
Yeah, absolutely. That's a great question. And for those of you who may not be aware of what polyvagal, one word, Polyvagal, polyvagal theory. And so the polyvagal theory is really a reflection of the autonomic nervous system. Let's start there. And The creator of the polyvagal theory, Dr. Stephen Porges, a good mentor and friend of mine now, really kind of helped me see things differently. Let me explain. I'm a pain psychologist, and my lens is the psychological version. If I was a physician and a surgeon, it'd be the medical aspect, right? Makes sense. However, what he has helped me do and help really have greater compassion for my patients, more so than I thought I ever had, was to bridge the nervous system. So you notice I didn't say the word mind or brain, I said nervous system, and that's where he comes in. The polyvagal theory really can be best summarized as the science of safety. Let me explain. I want you to draw, if you're taking notes, I want you to draw a ladder. Yeah, just draw a regular ladder, like a stick ladder we used to draw in elementary school, and put a bunch of those, staircases there. So draw a ladder, and at the top of the ladder, I want you to write to the right side, safe, S-A-F-E. And in the middle of the ladder, I want you to write stress or scared, stress/scared. And at the bottom of the ladder, I want you to write shut down. Now, there are fancy neurophysiological terms for them, but I'm not going to get into them. Happy to explain them. But just for common nomenclature here, the autonomic nervous system can be actually ranked in a hierarchy: safe, stress, shutdown. And a lot of people in chronic pain oscillate between stress and shutdown. And shutdown is like a flare up and sometimes the pain is so bad, you get very depressed and you don't want to live and you get really caught up in that. And then the pain kind of gets better. You're able to move around, but you're still not functioning. So you're oscillating between the autonomic nervous system levels, the hierarchy of stress and shutdown. And this is what tends to maintain it. Now, if we can break that cycle, we can break how? If we can get you not to complain about the pain, not that I've had pain, so I do understand that. If I can get you to be with the sensation without, as my Yiddish friend says, kvetching, hopefully I didn't get that wrong, without complaining about it, if you can be, another way of put by Pema Chodron, if you can welcome the unwelcome sensation, you will start to desensitize it. And so when you want to kind of change systems, the polyvagal theory says to create a sense of healing from certain chronic medical conditions, including chronic pain and trauma, depression, anxiety, there has to be a felt sense of safety in 3 areas. Inside of you, so when you have negative thoughts, very painful, scary emotions, heavy emotions, when you have a burning, aching, gnawing sensation in your body. So your nervous system is constantly scanning 3 domains: inside of you, outside of you, environment, overstimulation, inside of you, outside of you, and whatever or whomever is in between you. Emails, cell phones, videos, people, things in front of you. Inside, outside, and between. The nervous system, according to the polyvagal theory, is constantly scanning every half a second, asking one question of your nervous system: are we safe or not? Are we safe inside with my thoughts, sensations? And if you don't have skills, you're going to unknowingly promote a sense of danger. Like, how do I get rid of this? How do I get rid of it? The polyvagal theory says, am I safe or not inside? Am I safe or not outside my environment? Am I safe or not whomever or whatever's in between me? A human being, the pressures I feel, the doctors I have to see, my parents, my loved ones, whomever it is, inside, outside, in between. And that is how the polyvagal has come to be known as the science of safety. For you to feel a sense of safety, we have to do something to influence the nervous system. And at some point, Lonnie, I'd love to kind of demonstrate something very simple that everyone can do on the webinar. It just takes nothing but a few seconds, just to show you, to whet your appetite on how I teach people to deliberately influence the autonomic nervous system into safety. I'm going to pause you for a second because I've said a lot. I can definitely go into a brief skill. It takes nothing but just a few seconds, but it's a very powerful skill. I'm going to pause you for a second, see any questions or comments, and then if not, I'll just move into the demonstration.
we'll pause. I'll ask a question while we're trying to close this now. I mean, somebody comes to you, they've been having pain for a long time. They say they've gone all over they can afford it. They've gone all over the country. They go online, all of these different pain program promises, special techniques, etc. They still have pain. They find their way to you. How do you alter what already becomes a feeling of hopelessness, and how do you
Yeah.
motivate them to engage in this, what they see as, oh, one more failed, therapy that's going to fail?
That's a very profound and complex question, and I'll do my best to answer this. I often tell my patients this is, my job is not to convince you. Your job is to convince you. I've learned in my 20 plus years of doing this work, some 20 years ago when I got licensed and got excited, throwing this lab code, was in a pain medicine clinic at a huge health place. And I was trying to convince my patients that this is it, you got to do this. And I was very disrespectful because I was trying to convince people. My job is never to convince someone. Your job is. And one of the first steps we do is we do something called the Sherlock Holmes. I like Sherlock Holmes. And you cannot deny the evidence. And in my office, sometimes what I'll do is I'll do the demonstration and weave in the question and the demonstration here. Sometimes I'll have you focus on the sensation that you're struggling with and do something like this. And when I'll show you the intervention, and when you can experience a slight shift or relief, that's the evidence that you will start to create, like Sherlock Holmes, to stack against what you already know, but now of experiencing. So sometimes my job is not to convince, but to have you experience, just even for a few seconds, to show you the evidence that this is coming from the brain.
Could you do
All right,
a
so with that said,
demonstration?
if you guys don't mind, and by the way, I love having fun. Sure, go ahead. Demonstration? Sure, absolutely. So watch me, let me give you the instructions. I've modified this technique, and some of you may know it, and it's an old Japanese technique, and it's done differently. I've just modified it for pain reprocessing therapy to create a sense of safety through the polyvagal lens, which means I'm trying to shift your autonomic nervous system. So grab your thumb if you're able to, and it's not too painful. So here my instructions are very simple. You're going to do two things. When you breathe in, you're going to gently squeeze the thumb as you breathe in through your nostrils, pause at the top of your breath, and as you release that squeeze, I want you to shift your attention to your body. Feel the sinking, melting, letting go breath. Now, I'm going to raise my hands. You can, Lonnie, and the rest of you guys can be comfortable because I want to make sure you guys can see me visibly. Let's do this one more time. You're going to squeeze that finger as you breathe in through your nostrils, then pause to savor that goodness. And then as you breathe out through your pursed lips, as if you're breathing through a straw or trying to flicker a candle, as you breathe out, let the out breath be elongated. And I like to use these words: thinking, melting, letting go, releasing. Thinking, melting, letting go, releasing. So it goes something like this. So when you're releasing the squeeze, you are to take your brain's attention and place it in your body and feel the sinking, melting, letting go feeling, right? So let's do this. Let's do this. Take a breath in, squeeze the thumb. And as you breathe out, feel that sinking, melting, letting go, releasing breath in your body. Let's do that one more time at your own pace, breathing in at your own pace, squeezing and breathing in. Pause, and then gently breathing out, feeling that sinking, melting, letting go, releasing breath. Let's do it one more time for good old college try. Breathing in, squeeze and hold. And as you breathe out, focus on your body, feel that sinking, melting, letting go, releasing breath. Now, hands down. You would do this if you were in my office or virtually. You'd have 3 breaths per finger. And by the time you get to the third or fourth finger, you may notice a slight shift. And many of my patients do something really cute. Well, it kind of got better, but I still have the pain. And I say, yes, it takes practice to be a pianist. It takes practice to be an athlete. It takes practice to grow a muscle. And it takes practice to complain all day long. The point here is this. Practice is the drive changer of the nervous system, not a one-time wish practice. Practice, practice, practice. Lonnie?
Yeah, there's a question actually from Dr. Samantha Levy. Can you use PRT, pain reprocessing therapy, to help folks with chronic pain who function normally in the world and don't protect their site very much? Or is it only useful for people who are not functioning and protecting the area?
Great question. Very, very good question. So thank you for that question. It can be used for all, because if you actually pause and think about the premise of PRT is that it's a misinterpretation or misfiring of the brain. Let me put it differently metaphorically. It's like a dog that barks at a leaf outside the house, constantly overprotective. So the premise is there's a misinterpretation or an overprotectiveness, to put it simply. With that said, functional and non-functional, anytime we can promote a sense of safety, we increase our immune system, we stimulate the vagus nerve, which promotes a sense of biological healing, which then promotes a sense of psychological healing, which I like to say, based on that question, if we work off, if you're writing, taking notes, do this. Draw a circle, and at the top of the circle arch, write physiological states, physiological states. And then draw an arrow pointing down to the bottom arch of that circle and write this, psychological state. So here we go. Functional, non-functional, chronic primary pain or chronic secondary pain because of surgeries or other things or injuries in the body, immune systems, or non-structural. So physiological states really determine your psychological states. So if you want to shift your psychology, your fear, you have to physiologically calm something down in your brain. Physiologically calm the most primitive parts of your brain down, then the talk therapy stuff can work. So in that sense, whether someone is functional, non-functional, chronic pain, or chronic medical condition, what you always want to do is deliberately create a sense of safety by calming the brain/autonomic nervous system down, which then shifts your psychological states. Let me explain. When we feel safe and connected, we tend to believe we can psychologically do anything. When I actually psychologically fear my pain and avoid my pain, I reinforce danger in me messages. And when the danger in me messages, physiological states where I'm bracing, flinching, that psychologically promotes a sense of fear and avoidance, which then keeps us trapped. So this is why pain reprocessing therapy is about retraining pain in the brain.
For somebody who's had pain for a long time and they first come to you, it may be hard for them to understand that they can, that they cannot experience suffering. That, they've had it for so long. It's like Pavlovian dog. They know if they do this, they're going to have pain and it's going to be so bad. And they're not going to be able to go to work or school or what. If they do this, they've had that, it's like learned response in their brain. How do you begin to influence them that even that can begin changing?
That's a great, great question. It's one of the steps that we treat, and I'll just walk you over our 4 modules when I work with patients, and I'll address that towards the end based on the inquiry. The first step is to re-educate yourself on why do you still hurt, and that's based on modern pain science. The nervous system, the brain is being overly protective, and it's done its job. It's like someone has not told this person the war is over. and continues to be overly protective. Someone who's not trained your dog. I have a chocolate lab, like I said. When Bentley overbarks and overly protects, he's very protective of me. So kids are on the skateboard, he growls and he feels like someone's going to enter the place, but the kids are just going down the park. And so I've trained Bentley to actually, I'll walk up to him, tap him on his chest, rub his chest, and tell him, remember, shift your physiological states first. I tap and rub him, and then I say, thank you so much for protecting me. Very much like what I tell people to tell your brain. Don't talk to your brain, calm your brain down first, then talk to your brain. Step one, redefine on why and re-educate yourself. Why do I still hurt based on modern pain science? Step two, learn to actually have skills to not fear your symptoms, your physical symptoms. Step three, I'll go over this again. Step three, learn to effectively deal with your emotions, not cope, but really be thankful for them and really relate to them differently. Step four, which is what you inquired, exposure therapy. Exposure very often requires what we call graded motor imagery. I'll give you an example. Many of my patients have different pain conditions, including facial and dietary issues that they tend to flare up with. IBS, neck pain, chronic pain, complex regional pain syndrome. I can go on for days speaking about different conditions. And so when you have a particular medical condition that is not promoting pain relief, one of the things we do as part of the steps is we never go to the exposure part to help you desensitize until you do the first three. Let me go over the first three and then address this. Step one, re-educate yourself on why do you hurt based on modern pain science. It's the nervous system being overly protective. You are healed and everything has healed. Unless your doctor has said you have something very infectious or there's cancer or something that is very dangerous that needs to be addressed medically. It's always listen to your doctors, please. Step one, re-educate yourself. Why do I really hurt based on modern science? Step two, acquire skills to relate differently to your physical sensations. Step three, learn to relate differently to your emotions. When you have that anger, that fear, that sadness, that shame, what skills do you have? Talk therapy doesn't quite work. And I want to be gentle about that and not offensive. It works in certain conditions, not when you're trying to change the nervous system or the brain. There's a place for talk, but we want to welcome the unwelcomed sensations and emotions. Step four, exposure therapy. And one of the things we do is instead of getting someone, for example, with back pain or wrist pain or neck pain, we don't tell them to move their necks or backs. We tell them to imagine it first. It's called graded motor imagery, GMI. It's been well studied by Lorimer Moseley, an Australian physical therapist, professor, a world-renowned individual. Lorimer Moseley has shown that using graded motor imagery helps shift the brain system and the pain system. So with that said, when someone comes to me, we don't do the exposure or try to get them to shift and that condition fear. We have to do the first three levels first. Then we shift the condition fear. And by then they have the equipment, the new understanding, and they're likely to actually desensitize themselves. And one of the things Lonnie, one of the things that's great about this nonprofit that you have is it helps us not feel alone. The worst thing you can ever do is feel as if you're on a journey by yourself. And so the reason I love what Dr. Lonnie has created here is you don't feel alone. And the fourth step besides exposure is making sure you have community. Because when you are with the right community, you don't have to explain yourself or feel shamed.
As you're talking, I'm thinking of trauma-informed therapy. I mean, what you're describing, I'm not a psychologist or a psychotherapist, so I'm saying this as an MD, non-psychiatrist. Like pain has become a trauma, and it's almost like a PTSD. Uh-oh, here it comes. And what you're this graded exposure therapy is almost like trauma-informed therapy. Can you talk about pain from a psychological standpoint as a
Yeah,
trauma?
absolutely. Absolutely. One of the things we do, as we'll all find out very soon or sooner than later, to heal, you are to integrate, not segregate. It's not mind or body or brain or this or trauma or psychological. We're one system. It's called the nervous system. With that said, one of the important things is when people suffer with chronic pain, the chronicity of it and the medical and to some degree medical traumatization can occur. And these are my colleagues, by the way. They're good people, but they unknowingly sometimes say things that gaslight is what we call it. That's one. And number two, sometimes we traumatize ourselves unknowingly on I don't want to deal with this. How do I get rid of it? You're going to find out the more you try to get rid of your sensations, the more you get it. Let me explain. Metaphorically, when it comes to trauma or chronic pain or depression or anxiety, it's like quicksand. One of the things in surviving quicksand is when you're in quicksand, the more you fight it and try to resist it and try to get out of it, the more you sink. Metaphorically, in the same manner, for you to actually heal, you are to make full contact, even for 10 seconds. Even for 10 seconds. And let me explain this. You're like, how, Les? How is it even possible? This is one tiny, simple solution. In this man, we can call it finger squeeze or finger jujitsu, if you want to call it that. And so when you can be calm at the worst moment, when you feel a sensation, have a very powerful negative thought, a raw emotion, or a gnawing sensation in your body, when you can be calm and rest in that sensation, may that be a thought, an emotion, or a physical sensation, may that be trauma, may that be chronic pain, may that be acute pain, it doesn't quite matter. When you can be with that sensation, even for 10 seconds, and Lonnie, this is what I do. When we can learn to shift towards what we call bottom-up processing, and bottom-up processing basically means that when you feel from these brain parts, these are the brainstem and the limbic system, when we feel a raw sensation in our body or just get startled by a stab or a jolting pain, when you can, in that 90 seconds or even 10 seconds, just ride that emotion, ride that sensation by calming yourself in that sensation, you will start to desensitize and retrain the brain system. So trauma, chronic pain share the same circuitry. And you can think of it this way. If you go into your pantry and you open up your pantry or shelf, or you might have your plates, you might have your cans, soup cans, you might have some perishable food there. Same pantry, different shelf. Trauma, chronic pain. Same pantry, different shelf. Shared circuitry is the common language I want you to use. So with that said, trauma, chronic pain, actually a part and parcel. And then we can even put one more layer, is addiction. We can actually put, and I call it the trifecta. If you address the trauma, the addiction starts to be in recovery. If you address the trauma, doesn't matter what, whether it's childhood trauma, medical traumatization, car accident, death of a loved one, a terrible unforeseen situation, change in finances, a change in relationship status, doesn't quite matter. When you address the trauma, developmental trauma, or the chronicity or the acuity of the trauma, when you address the trauma, you get to the Achilles heel of the addiction and the chronic pain. I want to pause here. I have many doctors I treat, and they will tell me, which is really funny, many doctors, that they have no childhood traumatization. And I do agree with them. Not everyone has high adversity of childhood experiences, ACE. Not many people do, but some people do. There's a correlation, but I often ask people this question. If your back is hurting, besides your back hurting, in the last 6 months or a year, what else has been hurting in your life? And so ultimately I want you to walk away with this. It's not one or the other, but the integration of recognizing this circuitry in our brain and nervous system has a shared common service: your survival.
So I'm thinking, and you know, there was Dr. Meyer has a kind of put out the recent, or it's probably not a recent study. You talk about ACEs, that people with irritable bowel syndrome have a twofold incident of ACEs when they're young.
Yeah.
And but does that mean
Mhm.
every person with chronic pain has to work through kind of whatever childhood trauma they've had in order to
Yeah.
achieve a sense of well-being and, you know, not being beaten down by chronic pain?
Yeah. I love your question. That's such a good question that I hear it almost every day. I'm going to give you a very, very abbreviated version. No, you do not have to go visit your past. However, you ready for this, Lonnie and listeners? Watch this. The past constantly shows up in the present. And if you can show up differently to what shows up inside of you, outside of you, or whomever's in between you, if you can show up differently, relate to it differently with a sense of curiosity, compassion, with a sense of courage, with a sense of what I'm saying is, can you be calm during the storm, within, outside, or in between? And you will retrain your nervous system that was traumatized or maybe experiencing something overwhelming, such as pain. You will change it. So you don't have to visit the past. And I want to do a side note here. Because I used to train a lot of therapists and psychiatry residents, I want to say this very cautiously. Do not, therapists, if you're listening on this call, if you're hearing me, and an audience as you listen to this, not all psychologists and therapists are created alike. You guys know that. When someone says they're trauma trained, it means that they have evidence-based treatment of EMDR, brain spotting, somatic experiencing, those three major ones, just to think at the top of my head. When someone says, I do trauma therapy, they must have at least one of the three golden standards: EMDR, brain spotting, or somatic experiencing. Now, talk therapy does not change trauma. It might worsen it. It's like overcooking for a meal and not knowing how to Tupperware it. Trauma therapists know how to Tupperware what they've spilled over in a session so you don't leave feeling overwhelmed. Talk therapy does work when you're feeling overwhelmed, but does not change the nervous system. There's no evidence of that. So coming back full circle here is I want you guys to understand that the past constantly shows up in the present. And if you can relate differently, you will do sort of a light trauma therapy on yourself or with the clinician you're working with. So this is why it is really, really, I wanted to underscore the message. Your autonomic nervous system is constantly asking, am I safe or not? Your job is, when you have a negative thought, negative emotion, physical sensation that's overwhelming, in those few seconds, you have to decide how you wish to show up. And showing up with a sense of curiosity, compassion, and courage. You've heard me say this over and over again. That's the skill that helps promote a sense of healing, including the past.
So let me ask a different question. We see a lot of kids, a lot of adolescents, young adults who are on the autism spectrum, super bright, you know,
Mhm.
they some of them have what we call alexithymia. They have a hard time identifying and giving a label to an emotion. And some of them
Yeah,
may have also difficulty in using their imagination. You know, they're better sort of building things, mathematics, and I'm being global, not specific.
yeah.
How do you do pain reprocessing therapy with somebody who might have alexithymia or have a difficult time with identifying their
Mm.
emotion, a label to it, working with it?
Another great question, Lonnie. Here's the response to it. I'm gonna couch it under the framework of bottom-up processing versus top-down processing. By definition, bottom-up processing is when you feel that nociceptive sensation, that difficult sensation in your body. It shows up in your body. That's called bottom-up processing. Bottom-up processing basically says, can you show up and feel that sensation, irrespective of whether it's a thought, an emotion, or a physical sensation? So when you feel, a lot of people with alexithymia, when you ask them, how you doing? Fine. What do you mean fine? Okay. What do you mean okay? Good. You're like, geez, how are you feeling? And so they're not doing this intentionally. I love what you said and how you prefaced it. This is just who they are. They're neurodivergent, right? So this is how they show up for the world. Here's what I do. I don't waste time on that labeling. Black, white, short, tall, guilty, angry. I go after the body. I ask, how are you feeling in your body and where are you feeling what's in your body? And so when someone says, are you feeling anxious? And they've got a smile, but I notice they're breathing about 20 breaths per minute. I basically ask someone who is maybe high spectrum, for example, Asperger's, or someone who's alexithymic, or someone who says, like, I don't know. By the way, just to tease you, Lonnie, since you're a physician, a lot of my good friends who are physicians are like, what do you mean? How am I feeling? Well, I think, no, I didn't ask you how you think. How are you feeling? And they said, I don't know what you mean. So I often tell them, scan your body and tell me where you might feel a charge or tension in your body. That's where we start. That's bottom-up processing. And then they might say, well, I think I feel something here. Great. What color is it? And if you could label it one of four, happy, mad, sad, or scared. I work backwards. So I use bottom-up processing, feel the body. What do you notice? And then I do top-down processing, which is basically expectations and beliefs. So then I give them, do you feel happy, mad, sad, or scared? Ask a first grader, how are you feeling? I'm mad. Ask an adult, I feel guilty, indignation. What is that? The truth is always in the simplicity, Akram's razor.
Yeah, no, I love that because it's again, when I send kids who are on the spectrum to
Yeah,
psychotherapists, it sort of how do you work with somebody who, I mean, has emotions, but has a hard time labeling it and talking about it.
yeah.
They can easily talk about bodily
Mhm.
sensations. So that's
Yeah.
really, I want to invite people in the audience before we end. We only have like 7 minutes. If you have any questions for Dr. Aria, I see a number of therapists in the office and some parent, I mean, parents. I can keep asking questions, but I want to give people opportunity in the Q&A. So
And Lonnie, I would even interject here to say is to the audience, share what your thoughts are. Is this kind of hard to digest? Is like, do you have now a brain aneurysm with all this information I've dumped on you? Did this experience work for you? What did you experience? Just even any reflection or comments will also do. You don't have to have a question, but I encourage you, as Lonnie said, definitely ask before we wrap up here shortly.
I think, I mean, this is old pranayama from yoga, breathing techniques. It's hypnotherapy.
Yeah,
It's a lot of how to alter your belief system and expectations. And it's a
yeah.
wonderful way to do it that doesn't take a lot of background information, or it's just an experience. And I see now we have a ton of questions. So let me ask, uh, any feedback on how this would tie into sleep issues, particularly quality and falling, staying asleep?
Absolutely. I'll respond to that question in this manner. Why would you need to sleep when your brain is on high alert? Why would your dog need to calm down when it senses danger? So with that said, a lot of para-insomnias, so I just use the technical term insomnias, when not to be able to fall asleep, induct, maintain, or early awakenings, those three, induct, maintain, and early awakenings. Those three kinds of insomnias tend to be reflective of the brain's alertness, which means it's vigilant. So it'd be imperative for us to actually have not only sleep hygiene, as the good doctors will often recommend, but also this. You have to have a practice, just like when you put a 3-year-old down, it has to have a system and a predictability of calmness. A little quick tip as we move on to the next questions. I want you guys to try this tonight. Pull the covers over you. You might have the air conditioner going and pop one leg out. The boogeyman won't get your leg. Don't worry. I will say so. Leave one leg open away from the covers. Why? Because your body, your brain will regulate the temperature when it's too hot or too cold. So it's kind of a cool way to kind of tell the brain that you're safe. Intentionally do a body scan or intentionally place one hand over your heart, one hand over your belly, and keep slow your breath down until you go into sleep. If you awaken, repeat it again. Slow your breath down to send a message of safety. This is just a quick tip.
That's great. And I'm noticing that child psychiatrist Mary Chavaria is asking if your practice accepts new referrals. Answer is yes, I can tell. And is it within California, and is virtual an option? So I have a whole bunch of questions
Yeah.
after that. So a
Yeah,
quick,
absolutely. So, yeah, the answer is yes. And you just simply would go to hello@menda.health. So, or just go to the website and ask for an inquiry, menda.health.
and another question, what can parents do to communicate with current providers to potentially incorporate these techniques? And I'm assuming by providers, this mom can respond. I assume you mean psychotherapeutic providers.
Yeah, one of the most important thing is, education reaches people, the new latest modern stuff. It's sometimes just offering a link. If you want to understand about pain reprocessing therapy, you can just go to YouTube, type in my first and last name, Les Aria, like the hotel, ARIA, and Pain Reprocessing Therapy. I have a video, go through it, and then send it over to your therapist and see, is this something that you can kind of guide me with or get some training on? So I think we just have to be very gentle about this. It's frustrating, but sometimes when you get the right diagnosis, which means learned habits, neural pathways, or neuroplastic pain, you get the right treatment. As I was taught, the right diagnosis, the right data collected, the right diagnosis, the right treatment plan.
Yeah, this mom talks about not just counseling service providers, but pain doctors and
Yeah.
PT. And then just to comment, someone said that what you're talking about really resonates with her. Another mom said, if someone is doing self-harm, would this process be
Mhm.
able to assist with that, since it would help with the anxiety and depression?
Yeah, great question. I have a quick response to that. One, I hope that when someone is doing self-harm, there's a really clear reason why. And just real quickly for the audience, whenever someone does self-harm, they're flooded and they're numb. So they create self-harm to feel and to be alive, to have what we call a mood shift neurologically. That's one. Number two, DBT, dialectical behavioral therapy, is far superior to PRT, CBT, and all the other T's. And so dialectical behavioral therapy, DBT, that's the therapy that the person needs to have, not PRT.
Got it. Any last comments that you would like to make?
Yeah, I think one of the last comments I want everyone to know is this, is whether it's emotional pain, trauma pain, psychological pain, physical pain, spiritual pain, it all comes from one system called the nervous system. And one of the clearest message I can share everyone is shift your physiological states, and you will really shift your psychological states. And in turn, that will shift your physiology. Practice the safety parts, learn skills from people who know a lot about somatic experiencing, people who are trauma therapists. And so Lonnie really tripped over what many of my physician friends have come to figure out is PRT. It almost sounds like trauma light. And so what I want everyone to know is change is possible and it requires the right treatment and a greater understanding to let go of the old beliefs.
And again, I certainly want to thank you, Les. This was so
My pleasure.
informative, and your way of explaining things is just phenomenal. And I want to thank everybody for coming. Remember, go to buychip.org. We have all kinds of educational, social support, skills building, and creative arts. Anyone who wants to make a donation to keep these programs going, we'll accept $1, just whatever you can would be appreciated. Thank you again so much, Les. This was
My pleasure.
phenomenal. And you know how to get to his website if you want to learn more. So thank you all, and close up shop. We're just on time. Thank you. Bye-bye.